Now I'll have to get my little deal. Hi there, this is Dr. Bill Wyatt again with the American Orthodontic Society. And something came up here last week that I felt like I should share with the people that are working or looking at these videos and trying to do the best type of orthodontics that they possibly can. And also, if they're an individual and you have something you want done to your teeth and you're not a dentist or not doing any orthodontics and you are a dentist or something, you can take these videos to your orthodontist and let him look at that. That's fine with me if he learns how to do these things in school. But a lot of the orthodontic schools are not teaching a great deal of adult orthodontics and things that are really complicated. You've got teeth that are abscessed, and you have teeth that are missing and tilted and gone and all sorts of things that you can do orthodontically and come up with some amazing things that you can do for adults, and then you can work with them even into their 90s. I know I could do that. So I want to go and show you a second way that people, the oral surgeons, really correct TMJ problems. And I found this out just recently talking to my good friend Larry Spradley, who is an oral surgeon. He is retired now. He was our state president, and his partner, Dr. Dean White. Also, I worked with both of these men for years and learned a lot from them, as well as showing them a few ways that we did other things, and then several other oral surgeons. But let's get down to the business part of this now, and I'm going to just go to a temporal mandibular joint and show you some things about it that you might not be able to pick up just looking at these pictures. Now, these were cut out cadavers and were made years ago in Sweden, I think, in a college there, and I've used these and learned an awful lot from them. Now, if you're looking at this as the number one picture, in other words, this is when your mouth is closed together, and this is your condyle right here, and it's all the way up in the socket. And here is the eminence, or the fossa that it goes in, and that's in the temporal bone, so we call it the temporal mandibular joint. You know, it's the most complicated joint by far in the body. Now, this, you see this tissue right in here on the upper left side over here is what we call the retrodiscal tissue. Now, this tissue is very unusual. It is highly vascular, whereas this portion of the disc, let me try to draw where the disc is right in here, and it kind of comes across here. It has ligaments that hold it in the front, and also a ligament that goes up in the back, and when you open this ligament right here, this disc will slide back, and this one gets really wrinkled up, and this one will pull tight when you come in there. Now, the retrodiscal tissue, this portion right in here, supplies the synovial fluid, which is the slickest thing we know. We can't duplicate and get something that is as good as the synovial fluid, but it is pumped into the jaw joint tissue. Now, the jaw joint has a separation in here. You've got the upper joint space and the lower joint space, and this synovial fluid, as best I can come up with, is squeezed out of the retrodiscal tissue, which has all the highly vascular area and a lot of nerves in there, and it works kind of like your kidneys and cleaning that up and pumping fresh synovial fluid in here with food in it, and then as you kind of close and press on the disc, it will supply the tissue down here in this disc with food and takes away the waste products and purifies it and sends it back. It's almost like you had a little kidney up there that was doing this work. This is amazing how this joint works. And this goes on all your life. I'm actually 94 years old now, and I have good tissue on the condyles. I mean, this disc right here, I can put my fingers up here and open and close, and I can feel the head of the condyle right in here. And if I move my jaw one way or the other, it'll tell me. And if this gets inflamed, or in other words, if your retrodiscal tissue, if you get hit in the jaw and it drives this condyle back up in here and really damages or hurts this tissue, it'll get inflamed and swell up, and it gets big and pushes out here this inflamed tissue. Every time you chew, this condyle goes up against that tissue, and you'll have severe pain. And people have a chronic problem there with the teeth won't allow their jaw to come forward. That lasts for, I mean, it just be going on forever. And a lot of times back in the past, especially in the past 15, 20 years, they did not really look for the problem here. If you keep using it, you'd have pain in your neck, and you'd have headaches, and you'd have shoulder pain, all kinds of pain, and you have similar pains if your vocal cords get inflamed. My granddaughter is a musician, and she was telling me about inflamed vocal cords, and if you keep using them, you'll have these same pains that the temporomandibular joint has. So now let's get back to the point of getting together here. There's another way to deal with this. So I'm going to erase these lines here, and you know where we've got the condyle and all this, and this is the evidence again. And if this gets inflamed, in other words, something hits you in the jaw. My little niece got slapped with an elbow playing basketball. Everybody in any kind of sport that you might get bumped in the jaw ought to wear a mouth guard. It keeps from shoving this up into this retrodiscal tissue, and it's not far up here to your brain, and you hit somebody hard enough here, you knock them out because it goes to the brain real quick. So we want to take care of that. But when this retrodiscal tissue gets all inflamed and is sore, an oral surgeon can go in and open this up, and he can go in this area and he can cauterize the retrodiscal tissue there that's inflamed, and just shortens it. Now that keeps the condyle from going up here and bumping into this sore tissue. And that tissue gets so sore on some people, you just go to touch right there and it'll hurt bad, and those people just won't let you get your finger on it, you know. Well, if that's happening and you continue to chew and use it and push it and irritate it, which long chronic situations where the teeth force the jaw back in there, people will go for years sometimes without finding out what is causing this to happen. So the old surgeons have gone in there and they knew what it was. It was irritating this highly vascular tissue here. So they cauterized this and shrink it up. And now the condyle doesn't touch it, so these people would get relief from this. You can also, if you get hit and you got it inflamed, put ice on it if you can, and keep it cold, and you might heat it a little bit and then put some coal on it, keep it from swelling up. When this stuff swells up, it pushes the retrodiscal tissue out in here where the condyle presses on it there. And I'll show you that in a minute. I'm going to go through these 1 through 10, and when we open the mouth now, you'll see this disc that's kind of biconcave. You just think of it as something like this, and the front and the back of it is attached up in here, attached over here. This has the attachments and the muscle structure to hold it. And if you get a real hard blow on this whole disc can get pressure on it, and it'll push it out, and the thing will be sitting right out in here instead of up where it is. And then you open your mouth, and these ligaments get stretched out, and then it gets open pretty far. When you open it, it'll go like that. And you can hear the popping of this disc slipping back on. Then when you close your mouth, this disc will slide off. You won't hear it much. It just it makes a little noise when it comes off. So what we do in orthodontics, and what should be done in here, is move the jaw forward. If we move the jaw forward, in other words, we'll move this condyle instead of it being here. Let me erase this again. Say this condyle, we want to bring it out to here somewhere, and it gets off of this retrodiscal tissue and fix it where it can't go back into that tissue. Then the pain, I've had people hurt for years, really, and you put a splint in their mouth that makes them bring their jaw forward, but you have to come in here and put tissue under the splint. You have to build it up, your splint, where the teeth meet, and the pressure goes up the tissue, up through the bone structure here, and doesn't go back here. If you just advance your mandible forward, you will hit here, and then your lower front teeth will come in contact with your upper front teeth somewhere like this, and that pushes the jaw back, and that's not what you want if you move this out. If you move your jaw forward, then there's pressure on the teeth and pressure on the joint, and there's nothing holding off in here. This is the beauty of a mouth guard. See, you bring it forward and you bite down, you've got a 1/4 inch of something that'll give. If you get hit in the jaw, it'll do that. So there are 2 ways of going at this. Cauterizing but to do that, you've got to open it up and get to it. So we advance the mandible and get the condyle where it doesn't touch this inflamed tissue. And the way you can move the jaw forward and have them fit is the way I'm going to put this. I'll just make a little deal here. Like your condyle is sitting up in here, and your teeth are fitting together back here. Now, if you take a tooth that's headed here, and you're another tooth here and here, I'm trying to draw and come around the corner. If you tip those teeth in this fashion, then the teeth are tipped further, then they'll have to move their jaw further to get it interdigitated with the upper teeth. In other words, you might hit here, you tip the teeth, and now they have to bring their jaw out here. So we take a splint, put it in there, and have them close in a forward position. And that solves the problem. In other words, it gets the condyle off of this inflamed retrodiscal tissue, and the old surgeons go in there and cauterize this, sew them back together and everything, and that solves the problem from one side, and we move it in the other direction. To me, it's a lot better to move the jaw than it would be to do the surgery and go in, but that's the way the old surgeons have been doing this. I hope I don't want to irritate the old surgeons. I think the way of moving the teeth forward is much better than actually doing surgery back here, but I'm not. They at least learned what was causing the problem, and the problem is the condyle pressing in that tissue, and it's jaw position, and it doesn't matter what, if you don't get this condyle off of this swollen up tissue back here, then it's going to continue to hurt. You can put all the salves and everything. You can go in early and put anti-inflammatory and keep it cold and keep it from swelling up, and you can doctor it and help it enough to where it wouldn't bother you. I mean, mine hurt having some teeth removed or something like that. So thank you for watching. Now we've got so many of these videos out here now, and we try to cover everything we can possibly think of and answer any questions you have. And I like to talk to people where I can see them and talk to them and see what they need. And doing this video thing has allowed a person to send these videos all over the world to people. But I can't see you. I can't really look you in the eyes and talk with you and tell you what is wrong. So drop me a note or write, and we try to answer all these questions. I have several very valuable people that help me. One of them is Reverend Oliver here, who has given me a video here of what you have to do. You could put Bill Wyatt YouTube.com, and if you push on our circle or group, then it'll go and search out all of these and give you information on, say, deep bite cases or class 3 cases, and they'll have all these cases lined up, and you don't have to fumble through 500 and something videos to find out what you want to know. It'll just bring it to you, and you'll have 5 or 6 or 7 videos that have that solution or have the information of what you want to know. And I appreciate them. I'm not doing all this. Reverend Oliver helps me a lot. My granddaughter, or not my granddaughter, my daughter-in-law is very sharp in this, and she's helped me with many videos, and her brother helped me some. My older son, who is a dentist himself, was encouraging me to do this several years ago, and so we have this out there now, and I want people to be able to use it. So take the video that Reverend Oliver has given you, and he goes over. Now, many of you know how to find stuff out in there. You don't have to have somebody tell you how, but it helps to know this. Thanks for watching, and I hope you, let me say, I'm going to go through these slides. I'm about to run around. Now this is number 1, and this condyle is going to move now. I moved it some. Number 3, the condyle moves out here. The disc follows this double concave, the mechanics of it. It brings the disc with it. There's a tissue. This tissue is broken off here, and we're going to be going. Number 4 is out here. Number 5, the condyle is down in here, and the disc is all the way out this far. And now, number 6, it starts back. Here's the condyle again, and I used to think, well, the condyle had to go up in this place. It doesn't go up there. The ligament and the retrodiscal tissue, to get in contact with the space in here, the open, has to have a good way for this synovial fluid to get in here. Now, as it closes further up, watch this tissue wad up and go in. You see it coming around like this. Now watch it. Number 7, it's began to do more. And here's number 8. It's like this. Number 9, it's up in here. And the condyle is almost there. And I will go back to number 1, which pushes it right up in here. And when it squeezes this a little, the synovial fluid can be transferred from the retrodiscal tissue into the tissue on the upper and lower part of the jaw joint right there. So thank you for watching. And this is a complicated complicated joint, the most complicated one in the whole body. It's almost got a kidney in there that cleans that out and takes care of it. And the thing can last your whole lifetime. And so I want you to do this. And I'm going to close out now, and we'll say goodbye, and I hope you listen to this. Thank you a lot now. Bye-bye. What's that?